It was number 14. The patient's capnography waveform is present, but the end tidal is steadily rising. Patients becoming drowsy. Most
Mhm.
likely explanation. I thought it was due to hyperventilation, but apparently it's hypoventilation. So
Yeah,
obviously
right.
that was kind of a misread because obviously if you're not ventilating, your CO climbs.
That's correct. Yeah,
But I
because you're
thought if I
not
was
blowing it off.
hyperventilating, they weren't getting enough, and so it was just like increasing that way as well.
No, if you're hyperventilating, you're actually breathing faster, so you're blowing off more CO2, so your end tidal CO2 goes down.
Okay.
Because
Um,
the more you that's more CO2 that you get rid of, and then your CO2 number goes down. But when you hypoventilate for whatever reason, whether it's opiate overdose, benzo overdose, alcohol, neuromuscular disorder, anything that causes you to breathe slower or more shallowly, that's going to you're not blowing off the CO2 in that case. You're holding on to it, so your CO2 level goes up.
okay. And then so you said just to know why answers are wrong. So I got 13 wrong also. As an adult patient with agonal respiration should be ventilated at approximately. I
Adult
hit
patient.
20 because that was the high end of our like normal of 12 to 20, but the correct
Right.
answer was 10, which
But when we're
I know is the
ventilating, so in respiratory arrest,
rest.
when we're ventilating someone, we're doing one breath typically every 5 to 6 seconds.
Yeah,
So what was the answer on that one?
it was 10.
Okay, so yeah, so 10 would be, so if we do one breath every 5 to 6 seconds, 5 to 6 in a
It'd be
minute,
six.
that's going to
Yeah.
be 10 to 12.
Yeah. And then the other one that I got wrong was
Especially, and it's even more important, especially when we're ventilating, that we don't hyperventilate, because like that, when we squeeze that BVM, that whole thing has about 1500 cc's of air, right? So like if we were to squeeze every drop out of that bag, that's about 1500, but a normal tidal volume is about 500 mLs. So this is why we only want to squeeze the bag with one hand, ideally. So like even if they don't have a tube and we're just using a mask, we want somebody with two hands to hold the mask with two hands, and then with one hand we squeeze. Well, actually, with just a couple of fingers we squeeze, because there again, we don't want to overdo it with the ventilations, because the same kind of situation, we're actually going to blow off their CO2. We're going to blow off too much. Um, and even in head injuries, it's kind of an old way of thinking that we hyperventilate head injuries automatically, but we actually can cause a lot more harm with the hyperventilation than not. So it's better to, unless you have some specific reason, or if the patient is requiring it, sometimes that you have to ventilate faster because that's what the patient's body needs at that moment. But otherwise, if you're taking over their airway, or if you're having to assist them, if they're properly sedated, you want to breathe them 5 to 6, one breath every 5 to 6 seconds. So that's going to be 10 to 12 times a minute for an adult, or one breath every 2 to 3 seconds for a kid. Now then it becomes 20 to 30 times a minute for a
yeah,
kid.
I did know those answers, but like when I was physically taking the exam, I even wrote, um that it was low. So the notes that I took on that question was like for 6, it was low, too low. 10, I even put that it was low because the threshold for ventilation is like 10 to below 10 or less than 10, higher than 30. And I
Right.
was like, okay, so it was kind of like I was debating between 20 and 10, but I was like, I know 12 to 20 was like our normal. And then I was
Yes.
like, 30 is too high. So I was like, oh, but if I actually did like a math equation for it, it would have been appropriate to hit 10.
Okay. Okay.
Um, and then the other one that I got wrong, it was a total oversight, which I got excited and I just selected DKA, but it was 42 and it was which condition should you suspect? It was a patient with liver disease, which obviously that's my cue that I misread.
Hmm.
Liver disease is confused, has a sweet musty odor on the breath. And I was
Okay.
like, oh,
Was it
that's DKA. And then
encephalopathy?
it was actually hepatic encephalopathy. And
Okay. Uh huh.
liver, and yeah. And I like was reading that and I was like, oh my gosh, but that is what I
And
tend to do when I take
now, and
exams.
so in that situation, okay, but that's actually a good point. How did it describe? So I don't have the questions memorized, but how did they describe the breath?
Fruity, musty odor.
Okay, so the musty odor, or sometimes it'll be described as like an almond. I don't know how they come up with this. Sometimes it's described as an almond odor, but so fruity typically is kind of like DKA from the ketones. The musty odor is more of the ammonia.
Mm,
Um, Kind of think of ammonia like in a cleaner, kind of that stinky smell. That type of that situation. So what's happening is the liver is failing due to whatever reason. It's not able to detoxify all this excess ammonia. The ammonia ends up getting across the blood brain barrier, into the bloodstream, across into the brain, and that's what causes the encephalopathy part. So it's ammonia that gets into the bloodstream and then gets into the brain. And then when you have ammonia in your brain, ammonia kind of behaves like an acid. And so it starts to basically denature or destroy the brain cells. That's what leads to all the confusion, mental dullness, altered mental status, that kind of stuff.
okay. So those
Okay.
are the only ones that I got wrong.
Okay.
And
I mean, that's
then,
great. That's actually, I mean, that's great. And the thing is, you don't have to know everything. You don't even have to get every answer right to pass the test. In fact, nobody gets every answer right. The thing I want you to constantly ask yourself on the test is, what's the safest thing I could do? And the safest thing is not typically the most expensive. It's not definitely nothing outside of your scope. So the SEAD, SEAD, so nothing outside of your scope, nothing that's too expensive, nothing that's too advanced too quickly. Even when you have to do advanced things like intubation or whatever, there's typically something basic that you have to do before you get to that step. So, like with intubation, one of the more basic things that has to happen first, or that should happen, is pre-oxygenation, apneic oxygenation with a nasal cannula at 15 liters per minute prior to intubation. That's real basic. Nasal cannula before intubation, things like that. Um, or like, even like I said, long before you've got to intubate, there's other things that you need to do. Or long before you need to give fluids, there's probably other things for shock management that need to happen, like stopping severe bleeding, keeping them calm, keeping them warm, keeping them dry, things like that. So um, nothing outside of your scope, nothing that's too expensive, nothing that's too advanced, or nothing that's going to delay care. The other thing, so remember the seed tricks, and then constantly we're going to use the 5-star medic method of, number one, is there a safety concern? Basically, just kind of rehearse that in your head. Every question, is there a safety concern? Yes or no? If there's a safety concern, that trumps everything else we do, even over patient care, no matter how bad the patient is, no matter how sick or unstable they are. If there's a safety concern, that's the first priority. Whether the safety deals with BSI and we need to isolate ourselves some kind of way with some kind of equipment, whether it's that we need additional resources, whatever, or we need to not be there in the first place, we need to stage, that kind of thing. Safety is first, then sick or not sick. Okay. How do we know if they're sick? Increased respiratory rate with symptoms, increased heart rate with symptoms. How do we know that they're unstable?
altered
Um,
mental status.
Altered mental status, pale cooled clammy, pale cooled diaphoretic, delayed cap refill, hypotension. Okay.
Mhm.
Then all of our fixes come down to oxygenation, ventilation, perfusion, if there's something to fix for a patient. Or is there a time sensitive situation where, like, if they're unstable, that we need to do something now and rapid transport? If there's a time sensitive situation, we need to rapid transport. And that seems really basic, but when you just follow it over and over and over, it's going to get you 90% of the questions correctly. And on any exam, that's passing.